And with that, we're moving to another interesting segment, the fireside chat. This is going to be based on digital infrastructure to digital impact. And to kick off this session of fireside chat, may I please invite our moderator, Dr. 𝗵𝗃 𝗂𝗃𝗃, the Vice Chairman, Asian Cancer Institute, Medical Advisor, 𝗙𝗨𝗏𝗃 Foundation, GIFT City. Let's have a huge round of applause for our moderator, Dr. 𝗵𝗃 𝗂𝗃𝗃𝗃, please. I'd now like to invite our speakers for this session, Mr. 𝗗𝗏 𝗂𝗃𝗃𝗃, the Chief Operating Officer, PD Hinduja Hospital and Research Center. Let's have a huge round of applause as we welcome Mr. 𝗗𝗏 I'd also like to welcome Mr. Mandar Kulkarni, the National Security Officer, India and SEA, Microsoft, to please join us. Thank you. I'd also like to request Dr. Sujit Chatterjee, the Chief Executive Officer, 𝗗𝗵𝗴𝗶𝘁 Super Speciality Hospital, to join us. Welcome, sir. And last but not the least, may I please welcome Mr. Guruswamy Krishnamoorthy, the Chief Executive Officer, BPL Medical Technologies Private Limited. I'd also like to welcome Mr. 𝗵𝗃 𝗖𝗶𝘁𝘆, the Co-Founder and Chief Operating Officer of 𝗚𝗏. We just heard him, and we'd like him to join the panel as well. Let's have a huge round of applause. I'd request our moderator to please be cognizant of the time. We're going to be ending up by 4:45, so I'd request you to just ensure that we stay in time. Thank you.
Good afternoon. I think the crowd is thinning out. Probably this is the last fire chat discussion. I have esteemed guests and panelists with me, and one of the important topics to re-evaluate what we are doing and what exactly is happening. Today India has spent a better part of its decade in scaffolding the digital infrastructure in healthcare. Ayushman Bharat mission, then digital mission, a growing health tech startups and ecosystem and hospital network that have invested heavily in HIS, EMRs and connected diagnostic. This infrastructure is the story largely written at present. What remains unsolved is the impact story. The hospital operators, technology partners, medtech leaders, the honest question is whether the digital transformation that has happened, but what actually changed, that we have to see. Whether my nurses are happy, my doctors are happy, my staff is happy, or just I invested money, did the infrastructure, digital infrastructure, full digitalization, paperless hospital, and still I am working in the same way as I was doing previously. Whether it has made any impact on me or not. That is very important. What is the patient experience? What is the outcome? And what is the efficiency improvement? That we have to see. Today, in India's healthcare sector is at an inflection point, with AI projected to contribute $30 billion to India's GDP and a digital health receiving sustained policy attention. The next wave of investment and decisions will be made by the leaders who have already lived through the one cycle of transformation. Their experience, the wins, the failures, and the lessons is the most valuable input available to the sector as of now. So with this introduction, as the time is very short, I will be going through the rounds of questions with most of the panelists, and if at all any panelist feels that he wants to add whatever the next panelist has done, he is free to do so. We will finish the whole thing within the next 30 minutes. So we want to know, we have done the infrastructure, we have done the HIS, we have done the EMR. What has worked and what has not worked? We want to know it. You can reply this thing, that when Microsoft works with the health system across India and Southeast Asia, what happens, what patterns do you see in where digital health investments succeed and where they consistently fall short what was being promised?
Thank you. It's a pleasure to be here. The patterns are more or less consistent, and I'll summarize them into 3 points. Number one, we see success in projects which are outcome based and not technology oriented. Many times, and sir also talked about AI being more and more used, is being game changers, so on and so forth. So a clear pattern is we see when hospitals or healthcare providers are very clear in what problem they are trying to solve, and the technology platforms is actually adopted for that, we see that successful outcome. What I mean by that is adopting AI for the sake of AI doesn't really yield outcome, and I'm using AI as an example. But anything that they want to do, they want to use, they want to go for HIS, any other system, right? When there is a clear-cut purpose and outcome, we see that as a success. The second thing we have seen is when something is in line of the workflow, how the clinicians, how nurses, or how the whole patient experience is, anything that fits in line of that workflow, it is successful. Anything that is a siloed system, you just automate or digitalize a billing system or any other siloed system, or that adds to an additional step for a clinician or a nurse or even for patients, that fails. Right? These two things we have time and again see. I'm keeping the conversation beyond a specific solution, because these two things we have seen to apply to any solution. You talk about new technology, old technology, automation, AI, anything that has fit in line, anything that has got a clear outcome and a need, we have seen that to be successful. Third and final thing is something that has seen sponsorship of clinicians. So this decision of what system I implement, is it a medical project or is it an IT project? Right? That has been a very important consideration. Anytime this has been an IT project, it gets implemented well. You have successful milestone, but it doesn't really is a successful from an outcome perspective. Anything that is driven as a clinician's project, as a healthcare project, right? We have seen that to be successful, right? Any project, right? Whether it is AI or anything else adoption. So I think those three are biggest learning that we have, right? And if I extend to what has failed, any point of time the technology has come ahead of the medical needs, it has failed, right? It has not technology ahead of the platform, right? Where we have seen things like people have not thought about data access, how the control will happen, how it will fit in terms of overall clinical flow. That basically has not worked, right? So those are the biggest learning, right? Anything that is in line, anything that is driven by clinician, anything that fits in the flow is successful. Anything that comes as a either overhead burden, or somebody has not thought through the entire life cycle in terms of how the data control access, whether it will give the outcome that is desired, that has failed, right?
Very rightly he said, if it is a IT project, then it will be successful, but on a practical level it will be a failure. Now all the projects which are to be done in the hospital have to be generated through the nursing or the doctors, and IT has to cater to that. IT cannot take a front seat and people will follow it. It will not happen. So from that point of view, it is very important step. Every hospital has to take it. Now I will go to Dr. Chatterjee. Building the new super speciality hospitals gives you a rare chance to make the deliberate choices and the digital infrastructure from ground up. I am building few of the hospitals. I know you have a multiple choices and you can do so many things from the beginning. We know the failures from others, or we know what is happening in the field, and we try to add it. At least as of now, we are current with the situation. But what would you tell the hospital already in the mid-transformation that you wish someone should have told you earlier? What is that thing?
Well, good evening to everyone. Now, Dr. Karanjaka's question is that you've already started the race, and now somebody tells you that, look, this is available. So what I would do, if it's a startup hospital, what I would do is that I would do a reality check, is what do I need? Now, if I am, say, halfway through, like for example, I've done my backbone, I'm thinking in terms of doing the HMIS, I would like to also know how I can cut time as far as the OPD is concerned. Is it possible for me to bring in something which is related to OPD function. So therefore, there are softwares today that no matter what the doctor writes, all the doctor has to do is to take a picture, that image becomes digitized, it can be stored in your archive, or it can be sent to the pharmacy as a CPOE. So this is what I would ask myself. Is it possible for me to do this? No, it's not possible to me, for me to do this. Okay, so if it's not possible for me to do this, what do? See, ladies and gentlemen, there are only 5 things which run hospitals. There's admission, there's discharge, there's billing, pharmacy and stores. You get this right, you've got your hospital right. So if I've got this right, then after that, everything else is flavor. So if I need to do that flavor, then rather than do an IP system, I would go for the OP system.
Thank you. I will move to Guruswamy. The next question is to you. Having worked closely with the hospitals deploying medical technologies from the medtech providers' perspective, what is one assumption hospital got wrong about the digital and device-led transformation? And how should they approach it differently going forward?
Thank you, sir. Good evening to all. Thank you very much for DHN team for giving this opportunity. So I would like to start slightly different. Before I get into the assumption that went wrong, I think it's always good to, so since morning we've been talking about so much about digitization, AI, challenges from different stakeholders. I think we also have to take note of one point, that for sure the digitization, technology deployment, all of them have had an impact. It is not that they have never had an impact. Say, for example, I think today in India, more than 60 to 70,000 robotic surgeries are happening, right? And tele-robotic surgeries have started. And over 20 to 25 million images are being reported through tele-radiology, right? And there is an application of AI on the top of all of that. Analytics and AI, especially in the areas of lung cancer, breast cancer. So there have been impact, very clearly. It is not that the technology deployment and digitization have had zero impact. There have been impact, there have been outcome. Now, coming to the other side, some assumption probably that went wrong or could have been better. See, in a hospital environment, typically there are 2 types of workflow. There's an enterprise workflow, there's a clinical workflow, right? And wherever there has been a technology deployment in the enterprise workflow, it has worked. Since morning, if you have heard most of us talking about things, we talk about ROI, we talk about reduction in time, admission time, pharmacy time. All of these are productivity fundamentally, right? I mean, these are not clinical outcomes. In terms of productivity, absolutely enterprise solutions, there are several of them, HMS, HIS, LIS, RIS, whatever it is. All of them, many of them have had impact, and I think they're working pretty well because fundamentally they are operated by non-clinicians, and the outcomes are very clearly measured, and we all heard about it. There is a financial outcome, it is measured, so they have worked. Coming to the other side of the workflow, which is the clinical workflow, I think that is probably where we have challenges because they are run by the clinicians, number one, right? And that is an area where the outcome has been a suspect. The deployment of technology has been a mixed outcome, I would say. And clinicians obviously are used to not to adopt anything that doesn't have a definite clinical outcome. I mean, say, I'll take for example the device which we are used to. If someone wants to go and sell a CT scanner or MRI or a ventilator, we have to very clearly establish a clinical outcome, a clinical benefit of that particular technology. And the clinicians are very tightly engaged in assessing the clinical outcome, and hence they adopt a particular technology, and hence it becomes a success. Whereas if it comes to a digital deployment of a digital technology, so-called digital technology or AI, in any form of digital technology, I think that is an area where it has not been fully established, and that's an area to work on, clinical outcomes. Fundamentally because I don't think we still measure the outcome properly. Before even we start looking at what it is, we should start measuring the outcome. To start measuring the outcome, we also need to define what the outcome is. Right? I think some of those areas are probably areas to work on. So if I have to say the assumption, if I have to define it as an assumption, the assumption that deploying a technology in a healthcare delivery institution will have the same impact on enterprise and clinical outcome probably is a wrong assumption to make. Because they work in a very different context. These need a very different type of deployment, different type of engagement. And second point probably is another, when it even comes to the enterprise solution, where one of the assumption that could be much better is, we tend to go for a technology deployment without fundamentally cleaning up the underlying process. If you deploy technology on a process which is not good, the outcome will be equally bad. I don't think you can expect anything better. If you go back to the fundamentals of any process re-engineering, if you start with lean or a process improvement, process re-engineering, all that it says is before you start doing anything, even before you start measuring the defects in the process, first remove the non-value add elements in the process. If you take pharmacy as a process, if you take a discharge as a process, if they have 10 steps today, first thing is to understand, do we really need those 10 steps? Can it become 7 steps, 5 steps, right? Clean up the underlying process and then deploy a technology on the top of it. Obviously, the outcome will be amplified. If you apply technology on what it is today without cleaning up the process, I don't think we will get the desired outcome. So these are probably some of the areas to work on. I definitely don't want to say that there have not been outcome. There have been outcome. I think where there is outcome, adoption is good. There are more people going for robotic surgeries. More clinicians are adapting to tele-radiology, telemedicine, etc. But there are certain areas we need to work on. I think that is probably the change in approach that we need to take rather than saying a wrong assumption.
Thank you. I think what Mr. Gurumurthy has said, Guruswamy, as the assumptions and the expectations of a hospital are particularly based on some of the previous experiences or on some hearsay. And once you try to utilize that through the employment of various ITs, then you realize that it is not happening. But the problem lies with your system assumptions, and probably the outcome measures are not properly evaluated or being defined. So outcome is not known to you properly, and then you have a failure of the whole system. Having said that, my experience on IT and HIS, actually I had been using HIS for last 22 years. And almost 10 to 12 hospitals, I started it. Unfortunate part is that HIS is sold by the marketing people. They promise me the moon. They promise me that they will build a Taj Mahal in a new hospital. And when it actually comes, as late as yesterday I had somebody who was telling me everything will be digitalized and so fantastic. But in reality, it doesn't happen. The product person who is developing it or the product manager, if he comes to you and if he gives you a proper idea what can be the outcome, what you can expect and what you cannot expect, then probably your expectations and assumptions can be lowered down and you will feel that you are not cheated on that. Every time you have all these HIs taken, I don't know how many people are from the hospital background, but the moment you take a HIS, within 3 months, you have customization, charges for that. You say another pay 5 lakh rupees, another 10 lakh rupees. This was not in the original. Why did you not tell me beforehand? I would have done that. I would have told you what I want. I would have told you my process. So the question is mutual, not only my side, the failure is there on assessment and outcomes. It is also failure on the company to sell me something which is over and above which they cannot do it. Anyway.
May I just add a line?
Yeah, you can add.
You know, the most important part when you take technology is take the end users along with you. So if it is a nurse, the nurse has to tell you what she wants. So therefore, don't sit with the IT and decide when you don't know what the end user wants. For example, even the doctor. Now, whatever the consultant wants is what he should be asking the provider. You leave him out of it, you've left a big gap. You know, like for example, if I have to design a hospital and I have to design a nursing station, I'm not going to design it. I'm going to call a nurse and say, what would you want? So there's the same thing with IT. Ask the end user.
Absolutely correct. And comes through the experience of various hospitals.
Sir, if I may, instead
Yeah.
of my answer, whatever you're saying, it's a great point for me. And I want to add into that, maybe reduce time from my question answer, that's fine.
No, you can take full time.
These are, and thank you Dr. Sujit and Dr. Ravindra for highlighting this. I will tell you from the vendor point of view. You're a buyer, I'm a seller. So my point of view, there are two things I learned when I started off this. One is, when a buyer and seller implement something at the hospital, it needs to be a partnership. It cannot be one way. I cannot sell something to you and get off. I need to be with you. So what we implemented on that was that we build a SaaS solution. But for a hospital to understand a SaaS solution is a big problem in this country still. I try to solve that problem every day. What does a SaaS solution mean? That you pay me every month. And when you use, then only you pay. And you are always on the latest deployment. So, which is, there is a new 5 lakh rupees, 10 lakh rupees will never come off. And you only pay when I use. So for me to stand with you and deploy and keep running at the same pace as you want is equally important, because you can check me out anytime. Today when you buy an HIS, you cannot throw HIS out. Changing an HIS is like building a new hospital. It's such a big problem because your billing and everything is on top of that. That's the first point.
I've got to understand your language and you've got to understand my language.
Yes.
Now, there cannot be a fundamental disconnect here. You're a technology person from a completely different industry. And I am a nerd from another industry. So therefore, you and I have got to come to the same frequency. So before you try and design anything, or before something you come to sell me something, you and I have got to have a dialogue so you understand where I'm coming from. So therefore, your technology, you cannot twist it in a manner that I have to agree with you. And that, unfortunately, is what typically happens when a technologist comes and explains to the CEO and his team, we are in absolute twilight zone, not even understanding a damn thing, but nodding damn intelligently. Oh, yeah, I've understood everything. And then after that, you go and make such a mess of every damn thing. So therefore, what you say, I've got to understand. And what I say, you've got to understand.
That's exactly.
I will add to that. What he says is that every time in every hospital I had gone, I told my IT department, sit with the nurse, sit with the front office people. You yourself find out what they are doing wrong or what they need to do. Because I tell you, nurses or the junior staff are not so experienced, not so IT learned. And they may not know. If I ask my IT people, can you do this? Oh, we can do it. You have this module? Yes, we have this module. We can give this thing. Now, why it is not happening? The people sitting at the front desk or the nursing level, they do not know exactly that how it is to be done or whether it is available or not. Like all stores now, big stores, everything is on the shop floor. You can see and you can take. But here you have to ask whether you have this report, whether you have this report, and then he will say, yes, we have this report, we will give you. So, but to come to their mind, for nurses or the front staff, they have to be intelligent enough to understand that. But if you sit with them and you can tell, what you are doing repeatedly this thing, you want a report, I can produce a report for you. Give a report, they will be very happy. You work as a team, not as a service provider or not as a superman in the hospital. Whenever problem is there, then only you will land in there. No, this doesn't work. So probably IT has to be the part of the team rather than being a separate team.
May I just add again, is that, since you and I have had a talk just now, is that if you were to sell me a system, I would take you to my billing desk and I say, you do the billing.
Correct.
This is my format. Now you do the billing. Now when you do the billing, you will find out what the difficulties are and then you will be able to solve it in a manner which I understand. So I would put you through the billing.
Yeah. You reminded me of my early days of 𝗗𝗏𝗃. So when I started 𝗗𝗏𝗃, I used to run a travel company, a large travel company, 10,000 crore worth of transactions every year. During COVID, and then we said, okay, there are no great systems. We will make system in 21 days. Every doctor will have a beautiful interface, and that's it. We'll make a large company out of it. I went to first 6 months, everyone thrown me out of their clinics. I went to clinics, doctors, because thesis was built, if you solve for doctors and nursing, everything will get solved. Downstream is fine, which you just validated as well. For 6 months, I would go to clinic and everyone throw me out. This is during peak COVID days. And then I said, no, we were absolutely wrong and let's restart. I spent 2 years just sitting in clinics and understanding what do they do. For first 3 years, we didn't even reach any nursing home or a hospital. We worked only and only with physicians in their own private clinics. The day they started paying us, charging money from a physician who's running their practice is a hard problem. You know, whether it's charge $500 or you charge 5,000, it doesn't matter, but charging that money is a very, very hard problem, right? They will pay you for holiday, but for technology, oof, hard problem. We solved that, then only we did it. So thank you for raising this point actually, and reminded me of my early days at 𝗖𝗂𝗃.
So Deepak, you have a small question. You are running an AI-powered hospital OS in a real hospital. And
Multiple
what is
hospitals.
one place where you have seen AI actually move a hospital from infrastructure investment to measurable operational impact? And what made that work when everything else around is still in just plumbing stage?
Yeah, I think great question. We don't, as a company, ask hospitals to put a lot of infrastructure. So no servers, it works on our cloud, which works beautifully. The only infrastructure is laptop, computer, or a mobile phone, which is generally available in a clinic. We have fundamentally seen, and I work with multiple hospitals where when we started into this chain of hospitals, the number of digital prescription were in single digits. Today that number is upwards of 60-70%, and they have seen the revenue upside. This is a real world, one of the top 10 hospital chain in the country. And they keep paying me every year more money because more physicians are adding on to the bucket.
It has a significant impact on every industry and especially in healthcare industry. What has happened is now healthcare is data fiduciary. So you are no longer only healthcare provider, you are also data fiduciary. That means you are accountable for the data that you have, right? And when I say accountable for data, that means how you collect data, how do you process data, how do you store data is your accountability. That's point number one. Point number two, generally, right, I'm sure there are honorable exceptions, but how healthcare providers, hospitals deal with consent is there is one consent from, data consent from that you get signature and that's done, right? That's gone because DPDPA mandates you to, it's purpose-based data. So when you collect somebody's data, right? Today when you collect somebody's data in a hospital, there is one data consent from typically, and not only in hospitals, even when IT platforms or anyone else collects the data, right? Banks collect the data, there is one single consent from that I give you my data. It changes because now the data that is being collected is purpose-based. Why are you collecting data? And it is also revocable. So your customers, your patients now, or even your employees, doctors and nurses have right to revoke that data access. So they can say, forget me. Now, if you have taken one consent and that data is spread across your hospital systems, right? It's in your HIS, it's in your labs, it's in 100 other systems. You can't revoke the data because you don't know where that data sits. So now you need to have systems where you are able to manage that data across different systems. It can't be one monolith. So data moves from legal to compliance. It moves from legal problem to a compliance problem, right? That's the second one. And third and very, very important thing that all of us are awaking is cyber security. With this data, what we need to also look at is cyber security because one of the most targeted systems are unfortunately healthcare systems. You got all the data, you got complete data of patients, for doctors, of nurses, right? And ransomware is something that is making a significant impact on a lot of healthcare providers in India and globally as well, right? Recently, there was an international healthcare provider who was in news because of a cyber attack. With that, you need to also move from best effort basis to secure by default. Right? Secure by default means you don't leave security controls as an optional one, right? Let me try to do it. That goes away. The security controls need to be by default turned on. Even if that means there is a bit of inconvenience, they need to be turned on. right? So there has to be a minimum guardrail that needs to be deployed by all the healthcare providers, because DPDP again makes it mandatory. So I'll quickly summarize 3 things that I said, right? Because of the Data Protection Act, see, first of all, it is something that is coming for us as individuals, as citizens, as a big help, right? Currently our data is at the mercy of everybody. Our data is lying everywhere, right? So we are, as individuals and as citizens, at huge risk. Things are digitalizing, right, including our payments, healthcare, and our data is not really protected. So DPDP is really first step towards that. But with that, as a healthcare provider, as businesses, we have a risk. We need to move from legal to actual implemented controls compliance on data, because healthcare providers are now data fiduciaries, number 1. Number 2, it has to be well thought through. You need to have data systems, because your data is everywhere. It's not one control or one consent that will help. And third, along with that, you need to move from protect to assume breach, the zero trust posture that we talk in security, right? You are going to get breached. And that is true for not only healthcare, for every company that uses, or every organ that uses data and technology. So you have to move from best effort to really secure in operation, secure by default kind of a control. That's a major change that we will need to bring in. See, you have to start thinking about cyber security as part of patient security. Right? There are protocols in an hospital about patient security. Right? I am not a medical professional, but when I go to hospital, I see there are multiple protocols that are put in place. Right? Hospitals, healthcare providers, we need to think about cyber security as an additional layer to the patient security. Only then things will get the right attention.
I think we are running short of time. So one small question to everybody, and please be short in your answer. This is a general question. We have built the systems. What is one missing link you think that still stands between the digital infrastructure and measurable impact on the healthcare today?
I will say 2. I think one is clearly the measurement of outcome and evidence backed outcome. I think that is lacking, which is what is very important. And 2 is data portability and data transparency. In the absence of data moving from place to place A to B to C to D, this should be a suspect. You know, as a patient, when I walk in from one diagnostic center to a hospital to other place, my data should walk along with me. As a clinician, I walk from facility A to facility B to facility C to treat my patient. The data should walk along with me. If this is not there, then I think we'll still have a challenge.
Mr. Guruswamy already said it, right? Once outcome. So all IT projects, we have to look at outcome. But one important point I think we are still missing is making IT projects as a clinician's project. Right? We have to run them as a clinician's project. I think that's the only way we will succeed in transformation.
I would say adoption of technology by physician is the biggest hurdle today. That's the really starting point for any tech transformation, which is unfortunately very, very low in this country today.
The last word.
I think the entire genesis is that we don't incorporate IT as a subject in a medical curriculum.
Good. Thank you. So thank you all panelists for in short time we have tried to give whatever we know about it. I think the transformation from the healthcare and its impact probably will be a study for so many people to do in their own hospitals. Because as a CEO, as a group CEO or a vice chairman, I will put in money. But really what it happens at the dead end, that we want to know it. So from that point of view, it will be enlightening to everybody. Thank you very much.